Now we invite Dr. Raj Kumar Sharma. He'll be presenting on the dying art of scleral buckling.
Good morning, Mr. Chairman, sir, madam, all the distinguished audience. I would like to touch upon a topic very close to my heart, very sensitive about this, and especially after hearing the heroics of people like Saurav Luthra, Saurav Santra, and Pankaj. This is because scleral buckling we have been doing, and I know the chairman sir must have been doing it for last 50 years. I have hardly an experience. Yes, I hardly have an experience of about 32 years. So since its introduction in the 1950s, scleral buckling has been a highly successful technique for the repair of rhegmatogenous retinal detachment. But the popularity of this art, I would call it as an art, is waning gradually. I will discuss the reasons for that. The decreased practice may be partly due to recent advances in the machines. Now we are using 10,000 cuts per minute, and instrumentation, visualization system, the wide angle viewing system of the microscope, the intraoperative OCT, as many people are using, is probably making a pars plana vitrectomy more attractive procedure and sometimes more lucrative also. In addition, the inability of the learner to observe their mentors employing intraoperative indirect ophthalmoscopy in scleral buckling poses an additional challenge. So that these days, the younger vitreoretinal surgeons, I'm not blaming anybody. This is the changing times. We have to accept that. So, I mean, they don't strain their backs and they don't indent, they don't want to indent to see the breaks properly. If they start learning indirect ophthalmoscopy well, I know I have had many fellows from outside India who were surprised that you are using indirect ophthalmoscope for managing a retinal detachment. So this is a fact. Despite these issues, scleral buckling is the preferred treatment modality for many indications because it has lower costs. It avoids many of the potential complications of vitrectomy. It also preserves vitreous, which may be useful in future where you have to give an intravitreal injection. So every month we get about 4 to 5 cases of detachment who are referred to us for buckling, belt buckle, vitrectomy, silicone oil, written clearly, and it is not done by a general ophthalmologist. These patients are referred by trained vitreoretinal surgeons. Out of these 25 cases per year, we get around, we operate around 25 cases, and out of these 25 cases which were supposed to go for vitrectomy, silicone oil, second surgery for silicone oil removal, we do buckle, and more than 80% we are able to settle. Maybe in rest 4 or 5 cases, we have to do vitrectomy later on. So I want this trend to be reversed. We should try buckling in many cases. My indications are different. So advantage of scleral buckling we have already discussed. The cost is also low. You know, the machinery cost of a buckle, there's hardly anything, indirect ophthalmoscope, cryo, that's all. But PPV, as I said, is more financially lucrative in India also these days. So more people are doing vitrectomy. The number of cases of vitrectomy is going up and up and up, and scleral buckling is going down and down. These are the Medicare data from UK. So you all know the definition of a buckle. How does it work? It reverses the intraocular fluid and the forces. So management in brief includes identifying and sealing all the breaks with retinopexy, draining if required, and then tamponade, which may be external like buckle, or an internal tamponade. But a thorough preoperative examination is a must, and accurate drawing of the retinal detachment should be there. Scleral buckling is done like this. So why I am not against vitrectomy. I am just discussing the pros and cons of vitrectomy and buckling. If you avoid vitrectomy, the reasons to avoid vitrectomy may include posterior hyaloid remains quite adherent, especially in younger patients, which may be difficult. Vitreous is more formed, so itself can help to tamponade the retina with an internal tamponade. There is higher rate of cataract formation after vitrectomy, and the risk of redetachment after silicone oil must be kept in mind. And in various series, it ranges from 10 to 15 to 20%. So, and my feeling is that vitrectomy is the most unforgiving of any ocular surgery. There are many case series where they have done buckling for all types of cases, including PVR up to PVR-C. Phakics, yes, it does have advantage, and many people do agree that yes, phakics, young patients, inferior RDs, dialysis, we should do buckling. I agree to their point. But what I want to say is, I would like to give this opinion that buckling can be done in all buckleable cases, whether phakic or pseudophakic. There's a big controversy and discussion going on that no, in pseudophakics we should do vitrectomy. I don't agree with that. There are many series where we can prove that. In a short series of collection of cases which we published recently after doing 5,000 bucklings, and to top that, more than 10,000 vitrectomies for RD, vitreous hemorrhage, etc. Not that we don't know vitrectomy, not that we don't have instruments, but we should do buckles also. So in our published series of 200 something cases, we could conclude that scleral buckling, when done appropriately in the appropriate cases, gives the maximum visual outcome with the least cost and the need for consecutive procedures. The visual acuity in our series doubled in almost more than 80% cases. And 67 pseudophakic RDs were also there out of these 200 cases, where 59 were settled with buckling. So the success rate was 88%. Many such cases, I don't want to go into details, maintaining vision 6/12, 6/9 after even 20 years. So recently we got some of the cases and their wide angle photographs. You can see the retina is beautifully settled. Just 1 minute, sir. See, this is one case where the patient was advised transparent vitrectomy, membrane peeling, fluid exchange, endo laser, silicone oil, and look at the drawing. This patient was operated for buccal, and the vision improved to 660 on day 3. Another patient, wide angle photograph, recently operated. Another patient, retina settled, visual acuity was 636 after 3 days. There are complications of vitrectomy. Most common is the failure of the vitrectomy, but still it is a time-proven technique, and this is waning due to recent advances in machines, instrumentation, visualization system, and despite these issues, buckling is preferred technique in many conditions. It entails lower cost. Thank you. So my indications, again, phakic, pseudophakic also should be included.
Thank you.
Many questions?
Thank you,
I know
Dr.
there will be
Sharma.
many questions.
As you said in the beginning, I am doing it for last 50 years, and I am still doing it. Although my age prevents me from doing active surgeries. Recently, I read an article
Sir.
that it is upcoming in America again, and some centers are doing 40% scleral bucklings. I am a
That's good.
member of a WhatsApp group of Retina with 1,000 members worldwide.
Yeah.
And even in that, people are saying that scleral buckling is coming back. So don't be disheartened.
Thank you,
very
sir.
much.
Thanks for the encouragement. Thank you.